Hello, I'm Suresh Gunasekaran, CEO of University of Iowa Hospitals and Clinics and Associate Vice President for UI Healthcare. We are delighted to again be part of the Iowa Ideas Conference. Now in its fourth year, Iowa Ideas provides a unique opportunity to bring together a wide variety of different voices, perspectives, and thoughts to create a better future for us all. 2020 is a year that none of us could have predicted and has given us unprecedented healthcare challenges. In some ways, these challenges have made us better at delivering care, but it has also further highlighted the serious gaps some Iowans face in receiving adequate healthcare services. Let's start the discussions here and follow through to deliver better health for all. Thank you for being a part of this important discussion.
All right, good afternoon, everyone. This is the session on reimagining the future of our healthcare, the afternoon session. My name is Michael Wronski. I'll be the room host today. One thing we're going to say is we have a chat section for this session on the right-hand side. You can ask any questions, but we do ask you to be respectful. One of the great things that makes Iowa Ideas so great is we're able to bring a large amount of people with different perspectives and different ideas and beliefs to this program. So we just want to make sure that we're being respectful. And at this time, I will turn it over to Michaela Ramm, who is the mediator of this room, and she will introduce our guests to you.
Great, thank you, Michael. Hi, everyone. My name is Michaela Ramm. I'm the healthcare reporter for the Gazette, and I thank you guys for joining us today and choosing to be a part of the healthcare track of Iowa Ideas Conference. So as Michael said, we're going to be talking about reimagining healthcare. Obviously, the past several months have been very unique and challenging for all Iowans, but I think it's safe to say that it's been especially true for our healthcare systems in the state. Hospitals suspended elective and routine care very early in the pandemic. And weeks away from open enrollment, we're starting to wonder how Iowa's insurance will be impacted by this and what this could mean for Iowa's individual market. We're going to be discussing that and more, and what our healthcare systems have learned from this challenging time, and especially what are we going to be doing going forward and what this will look like in the future. We have a few experts in this field that will be able to talk to us about this, but before we kick it off, I would like each of our panelists here to introduce themselves and tell us their role. Panelists, would you mind introducing yourselves to the group today?
Sure, I can start. I'm Michelle Niermann. I'm the president and CEO of UnityPoint Health in Cedar Rapids, Iowa. I've been in this role for just about 2 years now, but have been part of the organization for really the entirety of my professional career. Came right out of the University of Iowa into an internship essentially, and have had the great fortune of growing up in the organization. We're comprised of St. Luke's Hospital, about 225 physicians and advanced practice providers who make up UnityPoint Clinic, post-acute care settings, several mental health care settings in the community and around the community, and Jones Regional Medical Center in Anamosa, Iowa. Thanks.
Good afternoon. I'll go next, Michaela.
Thank you.
I'm Commissioner Doug Ommen, and it's good to be with all of you. I've been with the Iowa Insurance Division now since 2013. Time is just flying by, but especially this year has gone fast. I've been serving as the commissioner since 2016, and so I've had the opportunity to work on quite a variety of issues associated with health insurance. Probably cover a little bit of it today, but in addition to health insurance, obviously we regulate property and casualty, life and annuities, and the whole range of insurance products. So it's, again, great to be with you today.
Hey everyone, I'm Suresh Gunasekaran. I'm the CEO of the University of Iowa Hospitals and Clinics, and I think I've been in my role for just about the same amount of time as Michelle, a couple of years, but I'm originally from Nashville, Tennessee, started my career at Vanderbilt Medical Center, and lived in Dallas and San Francisco before I got here. So look forward to hearing everyone's ideas on the panel.
Great. Well, thank you, panelists, for introducing yourselves. Before we get started, just a couple of housekeeping things. I encourage, as Michael did, I encourage all the attendees to start populating questions in the Whova chat as they think of things. We may bring them up throughout, but I will for sure leave 10 minutes at the end for our panelists to answer those. The other housekeeping thing, Doug has been kind enough to provide some information for some remarks he hopes to give later on in the panel. And for some of those data points that he will be referencing, you can find that at the bottom of our Whova page. It's under the handout section called Reimagining Care. You hit download, all that data will be there for your viewing pleasure. Great. Well, let's get started. Panelists, I wanted to know first, before we get into looking to the future, I was hoping you'd take a moment to look in the past. What has been the greatest challenge leading your respective organizations and agencies through this very unique and trying time? I'll leave it up to anybody to take it, but looking back, what has been the biggest thing that stands out in your mind?
Well, I can kick off things. I would say, of course, none of us, I don't think, anticipated having the opportunity to lead our organizations through a global pandemic here in 2020. In Cedar Rapids, we had the added impact of the derecho. So it's been a rather remarkable year. I think the thing that was, or things that were hardest from my perspective, in the early going, as we prepared to respond with the pandemic, was really around just the significant sort of uncertainty and fear that our team members faced. Obviously we've all learned a great deal about the virus as time has gone on, but particularly in that early going, just an understanding of how it was transmitted. Would we have sufficient supplies of PPEs? How could our team members stay safe and provide good care to our patients and our community? I have not seen in my 26 years or so of working in this field a degree of uncertainty and fear among our team members like I did in the early stages of this particular disaster. Healthcare team members are people that tend to run to the challenge. They want to serve, they want to care for their patients, and to see that bit of a hesitation in some cases as they worried so much about factors of personal safety, and very understandably so, was hard to work through. I think as things have gone on, the leadership challenge is really around stamina, fatigue. There's a lot to the aspects of care that we're providing, to reactivating our services as we've all endeavored to do, and people are trying to keep up with all of that, along with dealing with all of the challenges in their own personal lives. We've all been impacted so dramatically. So trying to keep that energy up to support resilience and the well-being of our team members has been the greater leadership challenge as the crisis is worn on, from my perspective.
Yeah, absolutely. Suresh, do you have any thoughts from your perspective as well as a healthcare administrator?
Michelle hit it. I mean, I think that it started with fear. We're left with exhaustion. And I think that continuum is really there. I think for us, it's how do we serve our own community as well as the whole state. So I mean, I think for us, it's making sure that we are continuing to innovate. Whether it's with the vaccine trial that we're working on right now, or whether it's the remdesivir or the walk-in clinics or the telemedicine. I think that, we think that these circumstances require different solutions. And in the face of exhaustion, I don't think we should give up on that Iowa drive to innovate. And the same thing I would also say is the high level of collaboration and cooperation that we've enjoyed with other healthcare organizations and providers around the state. The ability to work with Michelle, the ability to work with others, because when we need help, we've been able to get help and offer help and work together. So I've seen a high level of cooperation that's really reaffirming. I've seen so many different organizations put the community first. And I think that that's most days that comes naturally, as Michelle said. We are people that run into the fire. But I think it's nice to understand that we got a lot of partners, so we don't have to do it all alone all the time. I mean, there have been periods of this pandemic where we thought Cedar Rapids was just going to get overwhelmed, and Cedar Rapids rose to the occasion. And there were times when this campus looked like it was going to be overwhelmed, and it rose. And now it seems the Quad Cities and other parts. And each time, I think we get through it together. And so as much as some days, in this market, you think about it as a business and who competes with whom for which patient. These days, it's just how do we work together to make sure that every Iowan gets the care that they need. And so that's been our experience. But I will say and reiterate that the stamina that Michelle brought up is probably going to be the lasting effect on our healthcare workforce. This has just gone on forever in our minds, and we've been super busy and haven't gotten a day off. And I think that's probably the biggest leadership challenge, is personally understanding what your staff's going through.
Yeah, absolutely. Yeah, excellent points. Now, Doug, I know you sort of have a different perspective and looking back, and one of the most challenging things when it comes to the insurance market. But I mean, when you think about a public health pandemic, insurance might not always be top of mind, but I imagine it plays a big role. So could you speak on some of the bigger challenges that were faced in this realm over the past several months?
Certainly. And let me just begin by thanking Michelle and Suresh for all of the efforts that were put in on the front line. And I know it's not over, but again, not just to the two of you individually, personally, but just all of our healthcare providers that have really been kind of on the front line with this. So it is greatly appreciated. I will talk a little bit about the insurance markets and some of the issues with that, but just in terms of how we as regulators go about doing our work. I mean, we function in an office circumstance, and so we quickly had to go to telework during with the public health emergency. And at first, it actually, in terms of just day-to-day operations, it was very smooth. But in our work as regulators, and frankly, as we do that have communication with our insurance companies, I think long term, there are some benefits to what we've gone through in a way, but also I think that there's a lot that's being missed. And so your question really related to challenges. And I would just offer that in this remote environment that so many people are in, there's a lot of lost creativity. It's not the day-to-day work that doesn't get done. But those issues surrounding innovation and the work that I know because of the long hours that's going on in hospitals and the long work amongst providers to develop those efforts to save lives and to improve lives. From our perspective, that creative work has to get done as well. And when you're doing things by video conferencing, it's really hard. A lot is missed. So I would just offer that as our biggest challenge. I think the insurance industry has been able to be responsive to the changes. It took some nudging on certain issues. I mean, certainly issues surrounding parity in telemedicine and things of that sort, which we may want to talk about more later. But I would just offer that I think it's taken all of us, and I think by and large what I've seen in the insurance business has been a real eagerness to try to make sure that healthcare is being efficiently delivered, and that patients that otherwise might not be able to access their needed healthcare coverage are able to do so.
Yeah, absolutely. And I think, Doug, your final point really kind of touches on the next question I'm hoping to talk about, just all of these challenges that each of your agencies and systems had to go through, and sort of the larger public health consequences that have come about of this. I'm curious how each of you as leaders will carry this forward with your organization, and what big lessons you've really learned as a result. So I'm curious, I kind of leave it up to whoever wants to start, but what's kind of the bigger lessons that you've learned from this and intend to carry forward?
There are a lot of parts to that question. I'll start with the public health implications, and maybe we can kind of talk through some of those things and what maybe is implied from our somewhat different perspectives and stations, if you will, within healthcare. I think, among the things that have been concerning to us as a result of the pandemic. Of course, the pandemic itself, the pandemic has it has been the case with the pandemic, and it has made evident again, including here in Iowa, the impact of race in terms of healthcare disparities. So, I think as time goes on and we, as we can compile our statistics together, there's no doubt in my mind that we won't see the same kinds of impacts right here in Iowa, the disproportionate impact from a morbidity and mortality perspective that's been seen across the country. So it certainly shines a light on issues of healthcare disparity. I think that it's been very evident, I think, to all of us, and that people have delayed care. We delayed some of that as we made sure that we had capacity to care for that initial wave, peak one, of our COVID patients, and people have been fearful, in some cases, to access healthcare systems. So we have certainly seen, I know I've heard Suresh talk as well about, the added morbidity that people are now experiencing because they've waited too long, to access care, and that's everything from people with very chronic disease that is just exacerbating to, parents that didn't want to bring their kids into the pediatrician's office for immunization. So kind of shows you how fragile, that sort of system of preventative care and taking care of folks who are chronically ill can be, how it can be interrupted very dramatically, very quickly. So attending as a, kind of a health system administrator to those broader public health consequences are important issues. Suresh, I know you've talked a lot about what you've seen in terms of very, very sick people, coming in from across the state. So I'm sure you have things to add there.
No, again, I think Michelle really covered it well. I mean, I think that those are the key things. I would just agree and say that I think the other implication that I think that Michelle and I are seeing is that we're far more than serving our own county. That here in Iowa, that it's very interrelated, and we're only as good as that final mile to Iowans in rural areas, non-urban settings. We're seeing an aging of our workforce, the lack of providers in these communities. I think we need to continue to innovate to make sure that all Iowans have access to care, regardless of their financial circumstance, regardless of their zip code. And a pandemic is really kind of showing that the infrastructure is not the same, and that you are very lucky if you're very close to St. Luke's and what you're able to get versus 50, 75 miles away. And so I think that that's something that the state and us as a broader community are going to have to think about. And I think the second piece of it is just to understand, again, a certain part of health comes from personal responsibility, and that although today's personal responsibility is gauged in somewhat of a political discourse, Michelle and I know that the majority of patients that we see, a lot of personal responsibility comes into cardiovascular management, into neurologic management. A lot of this is how well can we take care of ourselves, and how well can we take care of one another when you look at the mental health crisis. So I think that there is a discussion about societal impact around people being able to take personal responsibility and, more importantly, receive personal support to do these kinds of things. And so I think that these will be some of the things that, in addition to what Michelle talked about, that many of us will have to continue to talk about after the pandemic, or risk finding ourselves in the same situation for a different reason.
Yeah, definitely. So Suresh and Michelle, as system administrators, how do you plan for these implications, for the potential of sicker patients who, are facing health disparities, or who are further away and may need more care? How do you plan for that? How do you think ahead to strategize for that?
Yeah, it's a really great question. It's multifaceted. I think, again, I think that it does, I think Suresh said it well, the essential nature of having as much as can be appropriately and safely delivered in communities across Iowa is very appropriate. The necessity of medical beds and critical care beds, maintaining that capacity, building up our nursing staff and other clinical professional staff, looking into channels to help people find their way into healthcare careers, which seem to always be needed in one way, shape, or form. I think that is key. Thinking more about what we call, what you hear referred to as social determinants of health, which are up to and including some of the things that Suresh talked about, and working with community partners to get back further to the things that contribute to people's health concerns. Thinking more holistically in that manner about health, I think, is a key as well. So those would be a few of the things I think that come to mind. It does cause you to think about your definition. As a traditional healthcare administrator, from being more of that healthcare system, the bricks and mortars through which you deliver care, to the things that contribute in their entirety to people's health.
I would just say I agree with Michelle. I think that in the end, for us, it's I think we're reminded of the people that deliver healthcare, and fundamentally, we need more people in Iowa. I mean, we need to train more. We need to keep more. We want to grow more. There's a tremendous opportunity. And that when we say that, we don't mean just physicians. I mean, across the entire healthcare workforce, there's a structural inadequacy in Iowa that we need to continue to try to ameliorate. And certainly at the university, we want to expand our training programs. We want to expand the number of providers we can convince to stay in the state. We want to expand our own services, but I think that at a certain level, it isn't about what we do by ourselves, it's what we do in partnership. And I think that the future of healthcare in this state will likely be how we, as individual systems, can come together and work together where it adds value, where we can work with community organizations. I think that'll be a big part of the legacy, because I don't think anyone can just do it on their own. But Michelle brought up a lot of good points about capacity and the social determinants that I think will ultimately be very important. And I think we're at a pivotal moment for Iowa, because I think there's either going to be states that get this, and they're the ones that are going to attract population and retain companies and retain families because they think it's a great community to be in, or they're going to be states that just unfortunately just don't get it right. I think that what we're finding is either you invest in healthcare for the long-term stability of the community, or you don't. And when you don't make those investments, I think ultimately it's going to help hurt the community as a whole.
Yeah, absolutely. Well, kind of switching gears a little bit to ask the same question to Doug, but in the context of healthcare coverage. After the pandemic, we're seeing sicker patients, more patients impacted by this pandemic. Does that have any big implications for the insurance market here in Iowa?
I would offer, the insurance market, and you got to keep in mind that when we talk about the insurance market, so many Iowans access their coverage through group coverage and employer-based coverage. I think our out of our just over 3 million people, we 1.7 million, or 1,700,000 get coverage through employer and group-based coverage, and that puts us in a good place, except during times when employment is an issue. And we've kind of seen that this year. We've seen how it has had a real impact. So to the earlier point about social determinants, oftentimes people that are at greatest risk are the ones that end up being sort of in the first trend line out of employer-based coverage, and that's troubling. But by and large, our system that we have in place now in Iowa is actually able to deal with most of that. I don't know, I'd be interested in hearing from the other panelists about the presentation of uninsured, how that has changed through this pandemic. But I do know that by and large, that the pandemic has stressed our insurance system as well. From the individuals that maybe early on in the year, because of the pandemic, didn't go and access the services they needed. That created kind of a slowdown for providers in terms of income. We got calls from a variety of providers. I know the hospitals, were doing what they needed to do, but there were providers, dentists as an example, that really kind of had to shut down. That's a problem economically for the way healthcare is delivered in our state. So on balance, it is all evening out, I think. Certainly the pandemic has gone on way too long for all of us. You know, the threat of lockdowns and shutdowns create all sorts of anxiety and for Iowans all across the state, none of which is good. But by and large, I would say the insurance industry is okay. I mean, the way it's designed is, you know, if they're collecting too much premium at the end of the year, we do the evaluation and consumers get rebated. They get money back. I would just offer that by and large, I think the insurance industry is managed itself pretty well through the pandemic.
Right, absolutely. Well, kind of switching gears back to a point Suresh and Michelle brought up about the workforce. Now, recruiting and retaining a healthcare workforce here in Iowa, especially in rural parts of the state, has always been a challenge. I feel like we've talked about this before at conferences and news coverage we've done, but I'm curious, you know, if we do reach a post-pandemic world or in the midst of this pandemic, if that challenge will change. Will it be harder to recruit and retain a workforce after they've kind of watched what happened in the midst of all this? I'm curious your thoughts on that.
Yeah, it's a really good question, and it's hard to predict a little bit. I would say that you know, a good thing if you've already pursued a healthcare career is that you've had a growing number of options, a lot of different settings of care in which you can choose to work. So again, it has been you know, a good field with a lot of different opportunities and a lot of flexibility to be part of, but it is hard work, and it has been you know, it has been uncertain and somewhat frightening, you know, work in this particular era. I would say, you know, in our case, you know, we tend to see in an economic downturn, we do tend to see turnover decline, at least for a period of time. So I think we will have a period of relative stability or a little bit greater stability, which allows us to, you know, continue to work and support and communicate with and, you know, provide greater support and other things for our team members to hopefully keep them, you know, parts of our teams. So, and I think some people will be drawn. You know, I think the appreciation that has been shown to healthcare workers of all kinds throughout this pandemic by the vast majority, you know, of people in our communities has been very heartening. So there may be a certain draw to the field in that way, but we are going to have to work at it. I'll, you know, kind of speak primarily to, you know, nursing and other clinical and support personnel. We're going to have to look and work in places that we haven't been before. And I think that's a good challenge for us. You know, diversity, equity, inclusion, such an important topic now. There are ways, I think, for us to work with our community to support pathways for people that perhaps haven't traditionally thought of themselves as being a person that could be part of healthcare. So, you know, I think it's going to remain a significant challenge for us for a lot of different reasons, and we will have to, you know, have that creativity and innovation that both Suresh and Doug talked about to be able to attract and retain folks to our workforces.
Okay, absolutely. Well, a question for both of the healthcare administrators here. You know, we've had a sudden growth in the use of telemedicine, mostly out of necessity because people couldn't really access their doctor's office and still needed the care. This sudden growth in telehealth services, I'm curious how you as administrators plan to utilize this in the future. Will this be a big part of your planning? Is this here to stay? I'm curious your thoughts on this.
So, see, Michelle, I will go first every once in a while.
Excellent.
But I think that for us, we as a campus have had a fascination with telemedicine for a long time. And, you know, I think this is probably the 7th year, 8th year that we've offered telemedicine. We are limited by the payment parity issues and how that works. But a lot of what the university does isn't always about the bottom line financially. So we've used it in a lot of different workflows, but we don't see it as a replacement for in-person care. I mean, at the end of the day, There's a value to in-person care. There's a value for a physical examination. There's a value for seeing the wound after surgery, all of these kinds of things. However, what we have seen is that there are so many meaningful healthcare interactions that can happen through telemedicine. And compared to 5, 7, 10 years ago when we first started with this, our community and our patients are so much more savvy at being able to use the technology and have what's necessary to do this. I mean, now everyone has a smartphone, and it can be a starting point for certain types of communication. Folks are comfortable with internet access and some of these things. But ultimately, the future on telemedicine will not be driven by the provider's willingness to do it. I think Michelle and I both know the majority of providers are likely willing and able to do it. However, the rate limiting step is, what are the economics around it? And second is that there are still technology disparities amongst Iowans. You know, access to broadband, access to devices, access to the knowledge, frankly, to be able to pull this off. So I think that in this, the healthcare industry might have a slightly higher appetite for wanting to deliver this than either the economics or the community can sustain. But it has been heartening that more equitable payment has been entertained during this pandemic that has allowed us to offer the service, and we've been very appreciative of that.
I think the only thing I would add to that is just to echo the gratefulness for the payment parity opportunities that have existed both through, you know, Medicare, Medicaid, but also commercial insurers in the state of Iowa. It's made a tremendous difference in terms of our ability to extend care through that means during the pandemic. You know, Suresh talked earlier about the importance of healthcare systems throughout Iowa and working together. Telehealth is probably a great example there, you know, because you can do a lot of things, you know, with telehealth, but what are the best things to do to tap into the resources of an academic medical center or a tertiary center in a larger urban community? How do you connect those back to those communities that don't have, you know, the provider resources or, you know, that access to get to Iowa City or get to places that they may need? Starting somewhere and having that access is really key. So, you know, this is probably an area where some of that, you know, sort of statewide planning would be of great value to us. And it happens, you know, kind of organically, you know, all the time. Someone, you know, has a need in a community for a specialty that exists in another community, and you kind of piece it together. But taking a planful approach to telehealth as a state is probably an ongoing opportunity for us. It's amazing to see how quickly it was adopted, though, you know, both by our physicians and advanced practitioners and our patients, you know, during this time. Just incredible uptake of that service.
This is Doug, and I would just simply add that it is a commercial determination as to how effectively it can be used. And what I mean by that is, I'm not a physician. I wasn't on that end of the phone. I was on the other end of the phone as a patient during the pandemic. And, you know, the provider, to the degree the providers learn how to do it and learn how to do it well and create a desire among patients to want it, that desire by the doctors, that desire by the consumers is what's going to drive ultimately the reimbursement rates. You know, in other words, the more consumers want it, and I think that there's a desire for it, that's what's going to put pressure on employers to adopt it as part of their plan. It's going to put pressure on the insurance companies in terms of parity. But I do view it as one of those areas that consumers got used to it, and I'm sure many doctors got used to it as well.
Yeah, absolutely. Doug, I was hoping you could, you know, answer this next question I have. I'm curious from your perspective if there is an appetite among insurers to have parity for telemedicine services. I know we have the state's largest insurer agree to it through the end of the year, but I'm curious, should we expect parity to continue becoming a big conversation, or do you think it's widely accepted at this point as more consumers use it?
Again, I would put it to some degree in the providers negotiate with the insurance companies on what kind of, you know, reimbursements are there. And I know sometimes the providers don't feel like maybe they're getting, you know, an opportunity to really pressure that. But I do view it as consumer driven. If patient, to the earlier point of Suresh about, it's not going to replace all medical care, obviously. But if you're a young parent and you have a sick child at home, you can make a trip to the urgent care. Or if your provider has access for telemedicine, that is something that I think consumers want. And I would just offer to that point, consumers are much more skilled at it now. Many consumers are, and it's going to take some effort in order to make sure the insurance companies understand that desire and that the providers are adequately compensated for it. So it's a combination of pressure points to kind of keep things moving in that regard.
Yeah, absolutely.
Well, Doug, I'll put in a plug that I do think that the patients are very much pushing for it, but I think the issue that we're trying to drive towards some clarity is what's the appropriate pricing for it, because I think that what historically has been done in the industry is to make telemedicine akin to a phone call. And I think what we've learned during the pandemic is so much more is possible through a telemedicine video-enabled interaction when it comes to a COVID patient, a heart failure patient. But when you look at the reimbursement models, when the patients have asked for it, the insurance industry's perspective is this is more akin to a phone call type reimbursement than it is the traditional evaluation and management that's possible. And so I'm hoping that what we're seeing is what family of care is telemedicine. And I think what Michelle and I have seen is it's closer to the in-person care than it is to what you do on a phone call. And so we're hoping that that's where the industry goes. And I know you and others have been very supportive of just kind of letting markets evolve, but I'm hoping that's the evolution that we're in the midst of.
Yeah, and I would just add to that again. I mean, as a patient and for consumers, there's a significant efficiency in being able to deal with it, as we have through the availability. Again, I'm not going to start calling out my particular provider, but once they adapted and had the technology available, it's slick. I mean, in other words, there's a lot of efficiencies by me not needing to leave work, not spend 30 minutes on the highway. In other words, that balancing of economics suggests that consumers should want this. So I agree with what you're saying about the insurance companies, but if I, as a patient, press my insurance company, look, cover this because I've saved 60 minutes of time on my end, that is pressure that should be applied commercially. And I think the companies, that is the insurance companies, if they don't yet appreciate it, I think, again, both collectively by providers, by consumers, they should be getting the message that this is an economic advantage to all of us. So that was my point. Thank you.
It's a good point.
Yeah, absolutely. Well, this question of telemedicine parity, I'm hoping in a bit to talk about the larger financial implications for these healthcare systems are facing in the midst of the pandemic. But before we get to the part, I'm curious if, getting this parity for telemedicine services, if this could be a good solution when it comes to addressing some of those financial challenges that are faced by hospitals across the state at this point.
A good question. I mean, I think it can be the sort of thing that can be mutually beneficial, as described here. I mean, it's certainly a good thing for consumers when you take, sort of cost, sort of holistically define the cost of their time, the cost of their care, and the like. Does it replace or is it additive in terms of sort of the, some of the financial challenges that many of us faced to a modest degree, but I think, the challenges that we're kind of facing from a financial perspective are in some ways larger than that, but in some ways, I think also, quite recoverable for many of us. Certainly it depends a little bit or maybe a lot on kind of where you started from and kind of your kind of capacity and your general financial health to begin with. So maybe a small part of the solution, but not in its entirety, to be sure.
Sure.
I would agree. I think Michelle is being generous. I mean, I think it's, at the end of the day, Telemedicine parity is more just to cover the cost of doing it because we want to be patient-centric, and it's really hard to be patient-centric in 2020 and listen to Doug and not offer it. I mean, it's a conscience thing. It's not a finance thing. It's a mostly don't lose your full shirt, lose your half a shirt or a third of a shirt type thing. But it's an important part of the continuum, and I think that Michelle and I both understand as providers that it steps beyond. We don't make every decision based on what part of the healthcare continuum makes us money. I mean, at a certain point, you need money to make it viable, but we would both agree that when the whole system is serving the community at its maximum capacity, that's when we do well. And what the pandemic has exposed is when only a portion of the system is being utilized, but we have the cost of the whole system here. It makes it really tough for us. And so what we need is society to go back to normal. What we need is that we have good access to healthcare. We need our supply costs to be the same as they were 2 years ago. We need employers to be employing the same number of employees. We need a strong Medicare and Medicaid system. All of those things, come back to play. So I think that our Christmas wish list might be a bit longer than anticipated, but it's one of those, you want Christmas past, every once in a while. Like 2 years ago was a really good Christmas. So we might want that, but I think we know we can't go back. So I think what we're all looking at is how do we innovate so that we continue to get patients to value a relationship with us, while also, and I think this is the important part, is advanced medicine. I mean, I think during this conversation, it only shows us the value of having access to the latest medicine, the latest technology, et cetera. When we make money in healthcare, all we do is reinvest it into the latest treatments, therapies, and staff for our communities so that they can get this care in Iowa and don't need to go to Illinois or Wisconsin or Minnesota or other places. That's really what our business is. I'm not aware of too many for-profit health systems doing much work in the state of Iowa. A lot of this is reinvesting in this community. And when we suffer, all that means is simply that the latest treatments and therapies may not be here. So I think it's worth staying committed to offering Iowans the latest therapies. And telemedicine is just one of those things. It does take a certain amount of investment to have the infrastructure to do that in a seamless way so that doctors can be just as effective and those kinds of things. But I think there are many other things that we think about too.
Yeah, absolutely. And speaking of, kind of the financial side of this question, hospitals in the midst of the pandemic have really kind of taken a hit to their budgets in the midst of all this as a result of the supply chain issues and suspending elective procedures. But a part of that, of what we're seeing is, if these hospitals, like you said, Suresh, aren't really making the money, they aren't able to invest it. And so I'm thinking of the community hospital in Iowa City that recently had to close an inpatient behavioral health unit, which is a service that is needed, but they aren't able to sustain it. So I guess, do you forecast more of that happening across the state in other hospitals? Is this financial challenge just going to make it hard for the next several years to maintain those services that don't necessarily make money, but are needed to maintain?
I think we will see some continued, changes in services that are offered in certain communities. I would anticipate that in many cases, the sorts of things that you perhaps see people doing or closing or reconfiguring are things that they, thought about before the pandemic and the financial pressures that we've experienced. And what we're experiencing is kind of what is now kind of driven, the final decision to move ahead in some cases. So that would be a little bit of my view, not knowing the particulars of anyone's individual circumstances, but I think we're all always, trying to understand, that mix of, services that we have and how needs can otherwise be met, or if they can't. And, if they can't, you want to do everything you can to maintain. But I think that, some of what you see will be something that, folks have considered for years. I think it depends, as Suresh said, how soon do we return to something that resembles, normalcy? I think our recovery curves to some degree, I should only speak about, kind of our own is fairly V-shaped. It's, not entirely that way. And then we took another bump here with the derecho, but that'll be very short-lived. So it really depends, I think, on people's, ability to re-extend their services and people's comfort and re-accessing them. Folks can get back on their feet, health systems can get back on their feet in a year or 18 months. I think that impact will be less, but if it's 18 months, 2 years, 3 years, you will see, more of some of those decisions to close certain services in some cases.
Yeah, absolutely. So how do healthcare administrators really plan around that? I think to your point, Michelle, you said we don't know how long this is going to last. And we don't have a date on when COVID-19 is officially over. So how do you plan for that?
It's funny, we're working on our budget now, and it's kind of like, sometimes people tend to think, well, budget year starts now, so COVID will be done then. Well, no, I don't think that COVID necessarily respects the fiscal year particularly run on. I mean, I think you try to endeavor, as you always have, to make your best assessment on, predict to a certain degree off the past. And, to do some forecasting around what the sort of worst scenario might look like from a financial perspective, and have some, intention about what it is that you would do, kind of in that gap scenario. Are you, kind of healthy enough to maintain, by and large, all it is that you do, because it's what you want to do in service to your community, or will you have to make some more significant changes if that worst case scenario is in fact, what you're dealing with?
Yeah, I think that the other possibility here is also, I know this sounds weird, but both Michelle and I have managed through different economic cycles. When, if there's a major change in Medicaid providers in the state, there will be financial ripples through the state. If there are recessions, there'll be implications to us. And so all of these kind of economic cycles are things that we end up having to plan for. And I think it sounds weird, but I guess now we start planning for pandemic cycles. And at the end of the day, I think that the way we think about our future is in 5 or 10 year intervals. And essentially the two things we look at are, what does the community need us to do? Being a state organization, an academic organization, we look at, for instance, over the next 5 to 10 years, if there is a significant aging of our primary care population of providers, if there's a shortage in the state for mental health providers, a shortage in the state for maternal health providers, then we change our plans to try to meet the community's need and continue to expand the services that the community needs. Because at a certain level, you hope that by meeting that community need, that you're doing the maximum good with the resources that you've been given. And so one way of looking at it is that healthcare organizations tend to, I know it's not just us, tend to look at longer planning horizons. So these 1 year crises end up delaying, as Michelle said, something we were probably going to do anyway, or accelerating something we were going to do already. But really, we tend to take the long view on what the community needs. And so for the most part, we're lucky enough to stay probably still full speed ahead, still do the things that we're going to do. It's just maybe timing might be changed associated with some of these things. So healthcare tends to be resilient in that way, but I know a lot of organizations were under a lot of financial stress pre-pandemic, and I think those are the organizations that are uniquely going to be affected by this.
Okay, absolutely. Doug, do you have any thoughts from your insurance perspective? How does the insurance market plan for this sort of thing, or plan around this particular challenge?
I don't think, although in the life business there is a fair amount of pandemic planning, I don't think that the health carriers really did plan in the same way, expecting it to play out or develop the way it did. I guess, Michaela, the title of our program today is Reimagining Healthcare, and our entire conversation has been looking at really 5 months of experience, which is, I think, part of my earlier comment about we have found it so difficult in the pandemic to really look very far into the future. I mean, we're in the midst of an election right now where, I mean, I don't know if any of you followed the Supreme Court discussion with Judge Barrett, but the ACA is front and center on that. And it's so difficult in this current climate to be thinking more broadly about, like, how can we reimagine the way things could be? And I did want to just point out, I know we're going to probably be taking questions, but I did want to point out, that material that I made available to those that are participating. I just want people to see that by and large, the Affordable Care Act, there are parts of it that are continuing to provide protection. I mean, over the years that I've been here, I've been pointing out flaws in it, things that I view to be fixable. But one of those areas is what I consider to be a subsidy or a income-only subsidy structure that really makes it a disadvantage for young people. And I know, Michaela, you've heard this from me, but a disadvantage to young people makes it a lot less attractive for young families. And so you're never going to get in that mix the right mix of population to make it work well. And I just, again, I would point out that it is somewhat working. I am not in the crowd to say, the ACA has been a total flop, because it hasn't been. And I think we just need to find that group of people to come together to find those types of solutions that can make it work better. I am a strong opponent of Medicare for all. I don't know if that makes me popular with the other panelists or not, but I view that in our state, we have 1.7 million people that rely on private group coverage. And that's a value that I would like to see preserved. But I'm a little bit anxious to get back to normal. What I mean by normal is having the ability to sit down and solve some of these challenges. And I'm very sympathetic to listening to the administrators on this call saying, like, we're just trying to figure out how economically, how can we manage into the next fiscal year? That's a bad place to be for an economy more broadly. But anyway, I guess, again, I would offer that I think we're going to be there. The insurance business will be there. But I think we do have to get the economy roaring again.
Yeah, absolutely. Excellent point. And a good point too about the changing political climate too. And it's not just about the pandemic, it's everything around it as well. So it is an excellent point and definitely a challenge our panelists will be thinking about going forward. Now, we have about 7 minutes left in this panel. So as promised, I want to take a moment and pause for attendee questions. So please use the Whova app or the website and start sending those in now. I see we have one from Alec. How is COVID impacting the training and recruiting of healthcare professionals? I believe we touched on this a little bit, but maybe the panelists could talk about the training aspect.
Do we talk about training?
Training, yeah.
Yeah, sure. I think that for the most part, for our direct workforce, we haven't been able to do large gatherings based training. So it's been more decentralized down to unit-based training with PPE and other things. It's also another area where in-person has been replaced by virtual. So a lot of the educational components have now moved to a virtual model, either in real-time instruction or in pre-recorded material that folks can go through. So we think that it's not great. Because we think the human touch is far superior, especially for new employees, folks in new roles. But we've seen a lot of folks on our clinical front lines really step up and replace that with unit-based and department-based training that's there. But it's just another part of the new normal that we're getting used to.
Yeah, absolutely. Great. Fortunately, not seeing any other questions pop in. So I guess last call for questions to come in. Otherwise, I'll let the panelists share final thoughts if they have any, or things maybe we didn't get to in the panel that they wanted to make a point to talk about today.
I would just say that despite all of the challenges, it's certainly been an opportunity for our organizations, to absolutely focus on the core of caring for our patients and our community. Absolutely been an opportunity for our team members to show their strongest selves and provide that care that we'd want, our own loved ones to receive. So, despite the challenge, it's been a proud time. And I do think, as Suresh has noted, it has promoted, that dialogue and that planning amongst this health system. So I think that's been, as you look for some silver linings here, that's been one of them as well.
I would just say thank you. We've been the great beneficiaries of a lot of community support within Iowa City, within the corridor, within the state, and we appreciate all the support that we've gotten from the community, from the Gazette, others. It's kept us going. Most days we don't need a lot of praise and credit and recognition, but we don't even have football in Iowa City. We could use some praise and support, and it certainly mattered a lot. But I would like to end the panel on, as much as we think about the future, and I think Doug's right, we probably didn't spend as much time thinking about the future. And I'm not a big fan of Medicare for All either. But the key message I would say is COVID's not over yet. So if you check the map, Iowa is not trending in the right direction. Michelle and I are decently worried about what this is going to mean ultimately for our bed capacity. Early in the pandemic, we talked about the healthcare system being overwhelmed. And we know there are plenty of Iowans that need to be seen for medical care for non-COVID conditions. At this time, going into the winter, if we continue to see the kind of transmission and spread that we see, we really risk overwhelming the healthcare system. Maybe not the whole system, but certainly individual hospitals are going to get overwhelmed. And so I really ask everyone in their local communities to do their best to follow social distancing, hand hygiene, and not attending large gatherings, face coverings, all of those things that we know work, that worked for us just a few months ago. We really do need to get back to that. Otherwise, we're really delaying our own futures. And so I really hope that everyone on this panel and on this in this meeting would support us in that effort.
I would just close by thanking Michaela, you as well as the Gazette, and to host this conference. These are really unusual times, but having participated over the last couple of years in person, it's still just very helpful to know that you can pull this off. So thank you for doing that. Really greatly appreciate it.
Yeah, well, thank you to our panelists for taking the time out of their busy schedules to participate in our a little bit out of the norm conference this year. But so far it's been great and I really appreciate it. So thank you to three of you for participating today and taking the time to talk to us today. Now we'll wrap up. For those staying on the healthcare track, our next panel will be the future prescription drug prices, which Doug will actually be on. So be sure to tune in if you want to see more of Doug too, and more conversation on that issue. If you have more questions for our speakers, please don't hesitate to reach out to them via Whova. There should be an option in there to message people. So thank you again, and hope you all have a good rest of your day.
Thank you.
Thank you.